The iron chelators are designed to bind to iron and remove it from the body in ways that would be more efficient than the processes by which the body gets rid of iron anyway. The only way that we have really to get rid of iron, other than by bleeding, is to shed cells from the skin that have a tiny bit of iron in them and shed cells from the gut that have a tiny bit of iron in them. So that's very inefficient. What a chelator does is it binds to the iron and then effectively pulls it out of the body by being excreted in the urine or in the stool or both, depending on the chelator. So these chelators can be given by injection. Deferoxamine or Desferel is the most common one that's given that way, and that's been with us for a long time. It's kind of inconvenient to get injections and get this every night by a pump, but it is tried and true. Then there are the oral chelators, of which there are 2 FDA approved in the United States, but only one is approved for a broad range of conditions that includes MDS, and that's deferocyrox or Exjade or Jadenu in the new preparation. It's an oral chelator that binds to iron in a way that seems to be a little bit safer than with deferoxamine. In that deferoxamine, there's still a little bit of iron exposed to organisms, so that some patients with deferoxamine have had problems with infections that we haven't seen with deferocyrox. Then there's a third iron chelator called deferoprone, or L1, that had been used for many years in Canada and Europe and in the developing world. And this agent is not as potent as deferocyrox. And the other problem with L1 is that it has about a 1% incidence of agranulocytosis. That is to say, the body stops making white cells. Big problem in MDS, obviously. And so the FDA decided when they approved this drug a few years ago in the US, we're only going to approve this for people with thalassemia or similar inherited disorders who didn't do well with the other chelators. So that one really is not applicable in MDS. There are a wide range of guidelines for chelation, and they differ in many respects. There's at least a dozen of them. Norbert Gatterman and I have summarized them in several articles. And I think whenever you have a lot of different guidelines with varying recommendations, it highlights that the evidence base isn't that great for making decisions. Most of the guidelines recommend considering chelation therapy after the patient has had at least 10 to 20 units of red blood cells, that the ferritin is over 1,000 or over 1,500 or over 2,000 or over 2,500, depending on the guideline, and that the patient has a reasonable life expectancy. So most explicitly say for the patient who has higher risk disease, chelation is a sideshow. It's a distraction from some of the more pressing concerns like severe neutropenia and progressive blast increase. So that's what the guidelines say. In practice, people do a wide variety of things with respect to chelation, and there are some who are very skeptical about chelation. There are other physicians who feel it's a critical part of the care of the patient with MDS, and most of us are somewhere in between. In my own practice, what I do is consider chelation in lower risk red cell transfusion dependent patients who I have some evidence for iron overload besides just a high ferritin. Because again, high ferritin can be seen in a lot of different states. So I will use a MRI test to help guide which patients are the best candidates for therapy. I find MRI useful for not only deciding who are the best candidates for chelation, those who have T2 star signals that are suggestive of heavy iron overload in an organ, But also you can use it to monitor effectiveness of chelation over time. So you could do an annual or even an every 2-year MRI to see, am I actually chelating effectively, or is the ferritin just coming down a little?